thank you for inviting me, Dr. Satyanarayana Garu, VC, and Dr. Jagannath Garu for inviting me for lecture on the DBS. So here I am going to talk primarily on the DBS of Parkinson disease. So because it is more commonly what we are doing surgery compared to other DBSs. So what is a DBS? So basically, so what is the DBS? So basically, whatever the disease in Parkinson disease, dystonia, there is a neurological changes are happening. So because of neural circuit changes are happening. To change the modulation, so we need a electrical current. So we give electrical current so that we give mainly subthalamic cortical structure, mainly nuclei. So different nucleus are there. So subthalamic nucleus, thalamus is there, GPA is there, and striatum. So different targeting structures are there. Primarily for Parkinson DBS, we use STN and GPA. So these are the structures located in the deep inside. So we use different methods to target. So what is the history of DBS? Actually, it was started initially the people who are doing electrical stimulation of the cortex, followed by striatal stimulation, followed by stimulation of the GPA, followed by hypothalamic region. Different nucleus they were doing. So slowly evolved into the full DBS. So what is the principles of this DBS? So how it works? What is the important thing? So basically here we are going to give a current. So the electrical. So cathodal act stimulation result depolarization, anodic hyperpolarization. It's a different monophasic, biphasic, triphasic stimulations we give, and monopolar and bipolar electrodes we use. Mainly the current what we use is amplitude and pulse width and frequency. All these three parameters we give so that it stimulates, in turn it modulates the neural circuits. So what is the mechanism? See, some people say hypothesis depolarization, inhibition, some people say excitation hypothesis, and the disruption hypothesis. Means it stimulates all the neural nerve endings. It results in the release of the glutamine, GABA, and acetylcholine, different locations it releases. So end result is there is a jamming effect happens at the target area. So basically, when we put a leads, we stimulate. So it go along the nerves or across the nerve. So depend upon the contact surface, they will get a stimulation effect. So if you give a narrow, so if it is a prodromal, antidromal, so if it is involving the axonal, it will potentially brings the clinical effect. But if it is antidrome, it will not give any effects. So basically in this Parkinson, so basically what we are going to do is in the STN DBS and GPA. So it primarily we involve STN DBS. It is hyper firing neurons will be there in the STN. So once we inhibit, the output will be the changed. See, especially in the Parkinson disease, the deep brain stimulation is effective. It gives effective treatment along with the medication, because it is successful in Parkinson disease compared to others. So how we select? So our neurophysician, he will select the cases depend upon his neurological condition, basically UPDRS3 score. So example I will show. So this is the case what we have done. This is a Parkinson patient is having bradykinesia, rigidity and tremor. All three has. So she was responding to the syndopa, but is only 1 hour, half an hour she is having response. If it is dose is increasing, she was having significant dyskinesis. So what is the best candidate? So all this was chosen by the neurophysician who are working with us. So primarily we choose the patients with the 5 years of the disease, and also the having disabling tremor, dyskinesia, involuntary movements, experience severe motor fluctuation, cannot be controlled with adjustment of medication. This is one of the most important point. So if we are unable to manage with medication, then the surgery point will come. And often experience significant dizziness interrupted with a rapid wearing off. Rapid wearing, this is the main indication for surgery. See, those who respond well to the D-base tend to be people who respond to carbidopa, had a typical Parkinson for more than 5 years, don't have severe cognitive function. So that is also cognitive issues should be very less. And also UPDRS score on of significant difference should be there. So basically the response, the which responds more is tremor, stiffness, and bradykinesia, dystonia, these will respond to the D-base. See, our as a neurosurgeon, primary aim is to target the subthalamic nucleus, GPI. See, accurate targeting is most essential for the outcome of the disease. So what, this is a red nucleus, this is the subthalamic nucleus. We use stereotaxic frame, stereotaxic guided navigation. This is called stereotaxic guided navigation. We use and we calculate according to the stereotaxic navigation. So the electrodes, initially we will do MER electrodes. So we'll put a initial inside and we record the brain from the striatum thalamus across the zona incerta and subthalamic nucleus, even SNR also. After recording, we will identify the structures. And sometimes we use GPI for the some Parkinson cases and dystonia also. So these are the targeting idiopathic Parkinson. We use more commonly STN. GPI is less, VIM is less. Tremor is more useful, but we have not done any case in the VIM. Most of the cases, our cases are STN DBS only. So these are the, see what are the advantages? See, subthalamic nucleus, there is a chance of the cognitive decline will be there. There is a globus pallidus, there will not be much cognitive effect, but the dose will not decrease. Ventral intermediate others, they have the tremor success rate is more, but we are not doing this anything anymore. More of a subthalamic nucleus or globus pallidus interna we are targeting. So how we'll plan? So the planning of the D-base, so first initially selection of the target and type of the electrode and all this will decide. And targeting based on stereotaxy based imaging and basically MRI we use, CT scan we merge both, and also after planning through the, so after this is a CT scan, this is MRI, this is CT scan. We both merge, we use these to get targets. With these targets, we target. So we do intraoperative monitoring and assessment, stimulation, and finally lead place. And after that, post-operative CT scan will do. Sometimes we may have complication. Rarely it will have only less than one. So this is frame is required. This is a CRW frame which gives the navigation. This is a CRW frame, fixed rigid navigation it is called. So this will we use for the targeting. So how you target STN? See, there are two methods of the targeting. Direct targeting, another is indirect targeting. We use a red nucleus method. From the lateral bottom red nucleus, it is 3 mm is the STN. Here, the identifying STN directly. So this is the navigation parameters. So GPA also use same method. So once the frame, so we make a two small holes. It is a 14 mm burr holes. We make a hole and we'll put a electrodes. These are micro electrodes, MER electrodes. So it has a two functions. One is recording function of the neurons, another is stimulation function. Because initially when we are recording, we're recording through all the structures which pass through, like from the except cortex, we go from the striatum, ventral thalamus, and zona incerta, subthalamic nucleus, and also SNR. So when we use the trajectory of MER, what I showed, so So there is, you can see there is a high frequency firing, large base will seen in the STN type of D base. This is the one of the classical. So these is not showing any firing. This says show there is a firing in the STN. So you can see once again. So there is a clear-cut evidence of the firing is there. So that is one of the clinical findings during the intraoperatively we can identify. So we have striatum, there is no much firing. The occasional firing is high frequency firing will be there, but very narrow base in SNR compared to STN. So all these will record during the surgery. So another important is when we target, so we have to target in subthalamic nucleus. It is a very small nucleus. It is around 5 mm to 3.75 mm. So we have to target dorsolateral area because the sensory motor area which locate in the dorsolateral area. So if you use anteromedial, which has a wooden cognitive disturbances, but if you do in the sensory motor area, so the success rate is more compared to other area. So because the we need, that's why we need recording and also the stimulation. So microstimulation. So when we do microstimulation, so we will see the response, the tremor response, and is there a dysarthria, is there a dyskinesia, or rigidity. All these will dyskinesia, bradykinesia, all these we'll see, and also side effects. Essentially, we will see corticospinal tract involvement, any stiffness, or dysarthria, conjugate eye movements, numbness, sensory involvement. All these will locate and identify, will place according to the proper place. So, and also macro stimulation, stimulation. So we'll see the, is there any side effects are there? Is a corticospinal tract or medial lemniscal or any paresthesia, any third nerve, hypothalamus, SNR, red nucleus. All these we'll see before placing the lead. So once placed it will look to be like this. So both electrodes which are going into the STN, so both. Sometimes rarely you will have complications like this. Is a usually less than 1% chance. It is a more out of 100 cases, one case can have. But even if in the advanced MRI with contrast MRI, the risk of bleed rate is very, very less now. So other related mild infection, sometime breakage, sometimes fits. Rarely these will have, but it is not much significant effect. A problem will come with because of this. So other is sometimes the cognitive effect will be there in the D base. That is because if you use STN, there is a chance of the cognitive effect. So what is the programming? See, because the location is the most important, then we have to use the programming to improve the condition of the patient. So when we program, we use 3 parameters: amplitude, frequency, and these. So we'll start after 1 month or 2 months. After that, we'll start using the low, from the low currents to the increase. So always the pulse width and frequency is more important. Frequency, high frequency, it inhibits the neurons. Pulse width, if it is patient is a gait problem, we have to reduce the pulse width. Otherwise, we have to keep it high, above 90. So what is the conventional D-base? See, in conventional, when we put a lead, so there is a, when we stimulate, so it will directionally, both directionally it will increase. See, it is a circular, semicircular or semicircular. It is a conventionally we will see, because in this, it may stimulate the surrounding structures also. So because of this, there is a recently new innovation has come in the leads and the leads. So where the first segment, initially the leads were circular leads. Now it is a segmented leads. So segmented electrodes which can stimulate in one area only. Second is sensing method. So this is a capable of recording local potential. So it is a beta recording. So it because it's like a biomarker. So that will be helpful for their programming. So directional. See, before I showed. No, so here the stimulation we can change. We can change one side or two different multiple current controls we can make. So and also side we can use and circular also we can use. So this is the advantage of the current new leads, which gives mainly reduced side effects and targeted stimulation. So the even if you have the near to the corticospinal tract, it can get reduced side effects. Targeted stimulation, expanded therapeutic window, and directional window provides a wider therapeutic window compared to conventional DBS, and energy efficient. So the current requirement will be less compared to this. So these are the current leads which is most essential. So these are the leads. These are the recordings. This is a stimulation amplitude. So these, because of the local field potential recording new biomarkers has come, this will aid in the programming. Next speaker is going to talk more about on these biomarkers, and so this is called beta power or beta band. So which will in the future it is going to program on its own. So like a beta power is correlated with PD symptom severity, is therapeutic target, feedback signal is adaptive DBS. So it can adaptive DBS can be done because of the beta power. So initially we investigate anatomical relation and both electrophysiological and biomarkers. So if both will give sweet spot for the targeting. So this is what we have done surgery before. Now after surgery, after 6 months after surgery, so she is doing well, and she had significant improvement, gait improvement, decreased rigidity. She had a mild dyskinesia because of the increasing current. So she was after 6 months. This is a recent one. So always should not think that it is a rosy, because sometimes what will happen is, see, recently it has come, there is a article automated deep brain stimulation. So using beta band, it stimulates automatically, but it is in initial phase actually. So this patient, see, we have done DBS after 1 year. Still, he is having significant freezing of gait. So we have changed all the parameter. We have not used in this case any directional lead actually. 1 year back we have done. So initial 3-4 months he was well. After that, still he was having significant issues. The freezing of gait, which is not controlled presently with the DBS, even medication also. So freezing gait is commonly observed is a freezing and on off or off FOG also. So that is a freezing of gait, one of the main problems in this, because the cortical modulators, a lot of cortical modulation is happening in the cortex region. Because of that, so it is not able to control the movements. Evidence says that motor cortex perturbation mutating postural gait process influenced by cognitive impairment, initial sensory motor condition, environmental perturbation, other factors also playing role. So transmagnetic stimulation has a role, partial role in this. Deep brain stimulation has challenges, needs further research to understand pathophysiology further. Final. Thank you all for the participation.
Long live India and France friendship.